Yeah. Shall we start? So 1 minute.
ಅಣ್ಣನಂದು ವಿಡಿಯೋ ಬರ್ತಾ ಇಲ್ಲ.
ಬರ್ತಾ ಇದೆ ಮೇಡಮ್. ಕಾಣಿಸ್ತಾ ನಮಗೆ ಕಾಣಿಸ್ತಾ
ಬರ್ತಾ ಇದೆಯಾ? ಓಕೆ.
Yes, sir. You can go ahead. Good afternoon. So I think as an annual affair, as most of you know, it is the May 10th, which is usually we work it out as a Lupus Day. I mean, I can't really call it as we celebrate. Actually, we work it out as a Lupus Day to increase the awareness about the disease lupus across to the patients as well to the public. I think as a part of it, we had one walkathon from our hospital around Rajaji Nagar. And tomorrow, another lupus support group is going to have a walkathon around Vidhan Sauda. And also we thought we would like to discuss along with our patients as well as their caregivers about their perception, their apprehensions, and their concepts about the disease so that it will help the public to understand what the lupus disease is. It is often said that the rare the disease, less likely people know about it, including the medical person. Though you are a rare person to suffer from the disease, the other people may not feel that you really have a disease because they are not aware about the situations. And that being the case, I think there is a need for public and everyone to know about this disease, lupus. Of course, it's not really a rare disease as we used to perceive 10-20 years before. And probably since the investigation facilities that were available and the suspicion for this disease was less amongst the physicians, the identification of this disease among the patients was lesser. That was one of the reasons probably we thought it is rare. Quite often, we think it is rare and that remains as a rare for quite some time. And now I think the number of patients who are identified with this disease have been increased. The reason is not that the disease has increased. The disease is remaining the same as it was 2-3 decades before, maybe centuries before. But we understanding and identifying the patient has become better. We are able to pick the patients much earlier in the course of the disease because now we know about this disease in a greater base. And second important thing that has happened is that the number of specialists, the rheumatologists who are practicing or immunologists who are practicing this specialty or these fields have also increased. That has also led to the increased identification of this patients suffering from SLE. And also the knowledge base of the both the family physicians as well as the internist physicians have increased. Those are all the reasons why we are able to pick these patients early. And we have learned a lot of lessons over the period of time that if we can identify the patients early, especially with any of these autoimmune diseases, including SLE, we can really make their life different. Because if you pick the disease early, you can stop the disease process, stop the disease damages in the very beginning of the disease so that things can be carried forward and they can really have a near normal quality of life. So that's where things work. And I think to brief on that, I request Shruti to just translate and put it across in Kannada and Dr. Binish to translate it in Hindi. And request Chaitra to speak something about the obstetric perspective of it. So I think Shruti to speak on Kannada, followed by Binish on Hindi. And then we open the forum for the discussion so that any doubts, questions, we are open. And you can also share your thoughts, your experience, so that the people know how it happened to you and how it worked. How did you work out the problems from your perspectives? Dr. Shruti.
ಹಲೋ ನಮಸ್ಕಾರ ಎಲ್ಲರಿಗೂ. ಇದು ನಾವು ಚಾಂದ್ರೆ ಟೀಮಿಂದ, ಚಾಂದ್ರೆ ತಂಡದಿಂದ ಈ ತಿಂಗಳು ಮೇ ತಿಂಗಳು ನಾವು ಲೂಪಸ್ ಮಂತ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಸೊ ಈ ತಿಂಗಳು ನಮ್ದು ಏನ್ ಥೀಮ್ ಇದೆ ಅಂತಂದ್ರೆ ಲೂಪಸ್ ಅವೇರ್ನೆಸ್ ನ ಜಾಸ್ತಿ ಮಾಡೋದು. ಸೊ ಆಗ್ಲೇ ಸರ್ ಹೇಳ್ತಾ ಇದ್ದಂಗೆ SLA ಅನ್ನೋದು ಇಟ್ಸ್ ಅ ವೆರಿ ರೇರ್ ಕಂಡೀಷನ್. ಸೊ ತುಂಬಾ ಜನಕ್ಕೆ ಇದ್ರ ಬಗ್ಗೆ ತಿಳುವಳಿಕೆ ಗೊತ್ತಿರಲ್ಲ. ಸೊ ಗೊತ್ತಾದ್ರೂ ತುಂಬಾ ಇವಾಗ ಗೂಗಲ್ ಎಲ್ಲ ಮಾಡಿ ತುಂಬಾ ಹೆದರ್ಕೋತಾರೆ ತುಂಬಾ ಇನ್ಫಾರ್ಮೇಶನ್ ತಗೊಂಡು. ಅಂಡ್ ಫಾರ್ ದಟ್ ಮ್ಯಾಟರ್ ಬೇರೆ ಫಿಸಿಷಿಯನ್ಸ್ಗೂ ಕೂಡ ಇದ್ರದ್ದು ಕರೆಕ್ಟ್ ಆಗಿ ಹೇಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋದು ಅದ್ರದ್ದು ಕೂಡ ಇನ್ಫಾರ್ಮೇಶನ್ ಕಮ್ಮಿ ಇರುತ್ತೆ. ಸೊ ಇದ್ರ ಬಗ್ಗೆ ಅವೇರ್ನೆಸ್ ಇಂಪ್ರೂವ್ ಮಾಡ್ಲಿಕ್ಕೆ ಪೇಷಂಟ್ಸ್ಗೆ ಮತ್ತೆ ಬೇರೆ ಮೆಡಿಕಲ್ ಟೀಮ್ಗೂ ಇದ್ರ ಬಗ್ಗೆ ಅವೇರ್ನೆಸ್ ಟೀಮ್ ಮಾಡಿಕೆ ಇದನ್ನ ನಾವು ಮೇನ್ ಲೂಪಸ್ ಮಂತ್ ಅಂತ ಹೇಳಿ ಸೆಲೆಬ್ರೇಟ್ ಅನ್ನೋದಕ್ಕಿಂತ ವಿ ಆರ್ ಹೈಲೈಟಿಂಗ್ ದಿಸ್ ಕಂಡೀಷನ್ ಈ ತಿಂಗಳಲ್ಲಿ. ಸೊ ಇದ್ರ ಈ ಆಸ್ಪೆಕ್ಟ್ ಇಂದ ನಾವು ಸೊ ಬೇರೆ ಬೇರೆ ತರದ ಎಲ್ಲ ಡಿಫ್ರೆಂಟ್ ಆಕ್ಟಿವಿಟೀಸ್ ನ ಕಂಡಕ್ಟ್ ಮಾಡಿದ್ರು. ಸೊ ನಮ್ದು ಚಾಂದ್ರೆ ಟೀಮ್ ಇಂದ ಜಸ್ಟ್ ಫ್ಯೂ ಡೇಸ್ ಅಗೋ ವಿ ಹ್ಯಾಡ್ ಅ ವಾಕಥಾನ್. ಸೊ ಬೇರೆ ಹಾಸ್ಪಿಟಲ್ ಇಂದಾನು ಕೂಡ ಇದ್ರ ಬಗ್ಗೆ ಲೂಪಸ್ ಅವೇರ್ನೆಸ್ ಬಗ್ಗೆ ಬೇರೆ ಬೇರೆ ಆಕ್ಟಿವಿಟೀಸ್ ನ ಹಮ್ಮಿಕೊಂಡಿದ್ದಾರೆ. ಸೊ ಇವಾಗ ಲೂಪಸ್ ಬಗ್ಗೆ ಬ್ರೀಫ್ ಆಗಿ ಹೇಳ್ಬೇಕಂತಂದ್ರೆ ಇದು ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿರೋಂಗೆ ಇಟ್ಸ್ ಅನ್ ಆಟೋ ಇಮ್ಯೂನ್ ಕಂಡೀಷನ್. ಎಲ್ಲಿ ನಮ್ದು ಓನ್ ರೋಗ ನಿರೋಧಕ ಶಕ್ತಿ ನಮ್ಮ ಓನ್ ಇಮ್ಯೂನ್ ಸಿಸ್ಟಮ್ ಕೆಲವೊಂದು ಆಂಟಿಬಾಡೀಸ್ ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡಿ ನಮ್ಮ ಓನ್ ಆರ್ಗನ್ ಸಿಸ್ಟಮ್ ಮೇಲೆ ತೊಂದರೆ ಮಾಡ್ತಾ ಬರುತ್ತೆ. ಇದು ಒಂದು ಕ್ರಾನಿಕ್ ಕಂಡೀಷನ್. ಸೊ ಈಗ ಬೇರೆ ಕಾಯಿಲೆಗಳಲ್ಲಿ ಇನ್ಫೆಕ್ಷನ್ ಆದ್ರೆ ಒಂದ್ ಫ್ಯೂ ಡೇಸ್ ಆಂಟಿಬಯೋಟಿಕ್ ಕೊಟ್ಟು ಅದನ್ನ ಕ್ಯೂರ್ ಮಾಡ್ಬಿಡ್ತೀವಿ. ಬಟ್ ಇದಕ್ಕೆ ನಾವು ಈ ಕಂಡೀಷನ್ಗೆ ನಾವು ಕ್ರಾನಿಕ್ ಕಂಡೀಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ, ವೇರ್ ನಿಮ್ ಬಾಡಿಯಲ್ಲಿ ಈ ಕಾಯಿಲೆ ತುಂಬಾ ವರ್ಷದ ತನಕ ತೊಂದರೆ ಮಾಡುತ್ತೆ, ಬೇರೆ ಬೇರೆ ತರದ ತೊಂದರೆ ಮಾಡುತ್ತೆ. ಸೊ ಕೆಲವೊಬ್ಬರಿಗೆ ಮೈಲ್ಡ್ ಆಗಿರ್ಬೋದು, ಕೆಲವೊಬ್ಬರಿಗೆ ಸಿವಿಯರ್ ಆಗನು ಆಗಿರ್ಬೋದು. ಸೊ ಎವ್ರಿ ಇಂಡಿವಿಜುವಲ್ ಇಸ್ ಡಿಫ್ರೆಂಟ್. ಸೊ ಇದ್ರದ್ದು ಸ್ಪೆಸಿಫಿಕ್ ಆಗಿ ಇನ್ಫಾರ್ಮೇಶನ್ ತಿಳ್ಕೊಂಡು ಅದನ್ನ ನಾವು ಕರೆಕ್ಟ್ ಆಗಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ಕೊಂತ ಬಂದ್ರೆ ಈ ಕಾಯಿಲೆನ ನಾವು ಕರೆಕ್ಟ್ ಆಗಿ ಕಂಟ್ರೋಲ್ ಮಾಡ್ಬೋದು. ಸೊ ಇದು ಒಂದು ಆಸ್ಪೆಕ್ಟ್. ಇನ್ನೊಂದು ಆಸ್ಪೆಕ್ಟ್ ಇದ್ರದ್ದು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೂಡ ತುಂಬಾ ದೀರ್ಘಕಾಲ ತನಕ ನಡೆಯುತ್ತೆ. ಸೊ ಅದರದ್ದು ಹೇಗ್ ಮ್ಯಾನೇಜ್ ಮಾಡ್ತೀವಿ ನಾವು, ಬೇರೆ ಪೇಷಂಟ್ಸ್ ಅದನ್ನ ಹೇಗೆ ಅವ್ರದ್ದು ಪ್ರಾಬ್ಲಮ್ಸ್ ನ ಓವರ್ಕಮ್ ಮಾಡಿದ್ರು. ಸೊ ಅದ್ರ ಬಗ್ಗೆ ಇವಾಗ ಇದ್ರ ಬಗ್ಗೆ ಮಾತಾಡ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಯಾ,
Over to you, Binish.
Okay. Hello everybody. मैं डॉक्टर बीनिश हूँ, एक रोमेटोलॉजिस्ट डॉक्टर चंद्रशेखर चांद्रे रोमेटोलॉजी सेंटर के साथ काम करती हूँ. और आज ये महीना जो है मई का महीना, तो ये महीना हम एक लोगों तक इस बीमारी जिसको हम लोग ल्यूपस कहते हैं, तो उसके जांच के बारे में हम लोगों को आगाह कराना चाहते हैं कि ये बीमारी क्या है, किस तरीके किस प्रकार से एक लोगों में आती है. तो ये महीना जो है हम पूरा एक ल्यूपस अवेयरनेस जिसको कहते हैं, ये महीना वैसे हम लोग मनाते हैं. और हम चांद्रे की टीम लेकर कल भी हम लोगों ने एक वॉक किया है पूरे राजाजनी नगर के इर्द गिर्द, ये समझाने के लिए, ये लोगों में दिखाने के लिए कि हम इस बीमारी को कंट्रोल कर सकते हैं कि अगर ये बीमारी बहुत जल्दी से पहचानी जाए तो ये, क्योंकि एक आम आदमी के लिए बहुत जरूरी है कि इस बीमारी को पहचाने पहले से. तो हम रोमेटोलॉजिस्ट या इम्यूनोलॉजिस्ट का काम रहता है कि हम इस बीमारी को बहुत जल्दी डायग्नोज कर पाएं, क्योंकि एक पेशेंट जो है उसका फायदा इसी में है कि अगर ये बीमारी बहुत जल्दी पकड़ी जाए. कल भी हमारा जो है कबन पार्क में रोमेटोलॉजी के सारे लोग जमा होके एक अवेयरनेस ड्राइव कर रहे हैं, जिसमें वो लोग वॉक करेंगे और अवेयरनेस सब लोगों में जांच फैलाएंगे कि ये बीमारी क्या है. दूसरी बात, पहले ही हम लोग बताए हैं कि ये जो SLE है या जिसको हम लोग ल्यूपस कहते हैं, ये एक क्रॉनिक बीमारी है, क्रॉनिक ऑटो इम्यून बीमारी है, जिसका मतलब है कि आपके जिस्म का जो अपने ही सेल या इम्यून सिस्टम है आपके ही बॉडी को अटैक करता है. वो पहचान नहीं पाता है कि बाहर का कौन सा ये है, कोई और जुज़ तो नहीं है जिसकी वजह के उसको अटैक करना है, तो वो गलत होकर अपने ही बॉडी के अंदर अटैक करने लगता है. तो ये एक ऐसी बीमारी है जिसमें पेशेंट को जॉइंट पेन या रैशेस ये सब आता है, लेकिन अंदर से ये हर एक सिस्टम को इन्वॉल्व कर सकता है. अलग अलग पेशेंट्स में अलग अलग ऑर्गन्स को भी ये इफेक्ट कर सकता है. तो अब तो इसका अवेयरनेस, मतलब ये पहले से बीमारी ऐसा नहीं है कि ये नई बीमारी है, ये कोई न्यू इन्वेंशन है, नहीं, ये बीमारी बहुत पहले से प्रेजेंट थी, ये हमारे पेशेंट्स में ऑलरेडी थी, लेकिन अब जबकि रोमेटोलॉजिस्ट के नंबर बहुत ज़्यादा हो गए हैं कंट्री में, और ज़्यादा नहीं बोल सकते हैं लेकिन एटलीस्ट इतने हैं कि अब लोग कोशिश करते हैं कि ये कंडीशन मिस ना हो जाए। और फिजिशियंस और बाकी डॉक्टर्स हैं उनमें भी इस बात का, इन बीमारियों की इंफॉर्मेशन अब पहुंचने लगी है, और इस वजह से ये बीमारियां इजीली कोशिश करते हैं कि ये डायग्नोज की जाए। Anything else, sir? Did I miss anything?
Thank you. Dr. Chaitra from reproductive and other areas.
Yes, sir. So like already sir and Shruti ma'am and Binush ma'am has told, one of the commonest autoimmune condition, ivaga SLE ಅನ್ನೋದು ಹೆಂಗಸರಲ್ಲಿ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಕಾಣಿಸ್ಕೊಳ್ಳುತ್ತೆ. It's more common in women when compared to men. So SLE ಇದ್ದಾಗ the risk of spontaneous abortions, preeclampsia or growth restrictions is higher. SLE per se is considered as a high risk pregnancy for a woman. So progressively we'll be answering your question. Being just an obstetrician before, I also used to get very scared of SLE patients when they used to come with pregnancy. But over the past few years, being trained by Dr. Chandrasekhar, I can now say when the condition is under remission, or when it is, sir usually says this is the best time for a SLE patient to get pregnant. When her state is quiet, when SLE is quiet, one of the best phases for her to get pregnant, to have a successful pregnancy outcome.
Yeah, thank you, everyone. I think now the session is open for discussions, question and answers. So you can unmute your mic and raise your thing, and any of you can come with a queries. Yeah, I think any one of you can have a discussions. Sudha, any ನಿಮ್ಮ ಕಡೆಯಿಂದ ಏನಾದರೂ questions ಇದೆಯಾ, ಅಥವಾ ಏನಾದರೂ you want to share the experience?
ಹೌದು ಡಾಕ್ಟ್ರೆ, ಕ್ವೆಶ್ಚನ್ಸ್ ಇದೆ.
Yeah, please go ahead.
ಹೇಳಾಗಿದೆ ಮುಂಚೆನೆ. So good afternoon everybody. My name is Sudha Rajashekhar. I am 77 years old. I have basically 3 questions. I don't know whether I'm allowed to ask 3 questions or not. Anyway, I have 3 questions. I am a patient of SLE since 25 years. Of late, my SLE has changed itself to rheumatoid arthritis. Is there any chance it might revert back to SLE? My question, all the 3 are to doctors, rheumatologists.
See, one of the thing with reference to this autoimmune disease, it can switch its gears. So I keep telling sometimes that it switches gears, sometime to the good, sometime to the bad. So we have seen from rheumatoid to SLE, SLE to rheumatoid, but it's only in 5 to 10% of the patients suffering from single disease switch their one point to the another points. So in your case, from SLE to rheumatoid, in a way, it is good because rheumatoid do not touch on the internal visceral organs. It predominantly causes pains and aches in the joints. And as I remember that your ANA has slowly come negative and your rheumatoid factor anti-CCPs have come positive, which was to be negative earlier. So it's a rare process, but it is not exceptional. It is well reported that switch gear happen because this immune system, which is responsible for this disease, is a very dynamic system. It is built like that. It is structured like that. Basically, because it is structured to defend our self from the myriads of microorganisms, which can keep changing their shapes. I think now with the COVID, all of us have become wiser and we know that a virus can change its shape. So first wave shape was 1, second wave shape is 2, the third wave shape is 3, and we know that there is shapes of this virus can keep changing. So immune system has a potential to change the way it works or it attacks. This potential, it has been built up to defend against these changing viruses and changing bacteria. When it attacks you also, it can change its target. It changes the target from one to another. But usually, as long as there is a continued challenge, it keeps the same track. So that's why we don't see much switches once the disease process, but we do see. Once the patient goes to remission, it suddenly switches its target. And it's one of the real problem that what we are facing, but we have now understood that this can happen. And there are studies, works which are going on, how to block that process so that we can achieve a long-lasting close out of the disease. Actually.
Very good. My second question is, as I told you earlier, I am a patient of SLE since 25 years. Now, my question is, none of you please laugh. Am I pretty serious? How long or how short I might live? Is there any deadline after 25 years of SLE?
Actually, if you have no hesitation, if you can divulge your age, I think others will be more comfortable in answer the question that I can answer.
Okay, any other doctor?
No, you didn't tell your age to my other participants, actually.
I told in the first
77 years.
77 years, actually. See, that gives a confidence to the rest of it, that
Yes.
the life expectancy is, if properly managed and taken care, is cut short by very limited amount. So if the treatment goes right, normally a cutting short of life expectancy is as good as a diabetes. Even if person suffers from diabetes, person suffers from hypertension, or if he smokes 2 pack cigarettes per day from his age of 20, whatever the time duration that has been cut, that is the time duration is cut in a well-controlled, well-treated SLE. But if you take an average, see, the problem in SLE is, there is some confusion if you read a literature. See, in a literature, what we say is, if you say that on an average, SLE cut shorts the age by 15 to 20 years. See, what is really happening here is, we are actually considering some of the very severe and very aggressive SLE where kidneys are involved in the very beginning, or where the nervous system is involved in the very beginning, and the patient approaches the treatment very late in the course of the disease, we lose them in the very early. So what happens is, when I give a average age reduction of 100 patients, the reduction what we talk about is very big. It looks like it is 15 to 20 years. See, it's what happens is, it is like taking an average of a 150 candidate classroom. What is the average score of this class? Means the average score will be around 50, 60. So you would have forgotten that there will be 30% of the candidate who would have scored more than 80% of the scores. See, this is a confusion that prevails when we talk of 100-member statistics. If a disease is well controlled, well recognized in the very beginning of the disease, in that group of patients, the reduction in the life expectancy is as good as a diabetic patient's. I hope I have made things clear about that.
My third question is, one of my niece is suffering from some sort of skin allergy since 3 years. She has undergone all sorts of tests and taken all types of medicines like allopathy, homeopathy, and Ayurveda and all that. But nothing has worked but her. She is still suffering. Do you think her disease is connected to any autoimmune disease like SLE or...
Anyone else? It's very difficult to say without seeing the patient. But see, if you're saying it is because of allergy, then it is not an autoimmune disease. There are 2 different immune diseases. One is what we call autoimmune disease, another what we call allergy diseases. In allergy, the immune reaction has been mounted abnormally on an outside protein. In autoimmune disease, it is the inside protein. So both are 2 different spectrum of diseases. So I'm not really sure what the case that is up to. If it is allergy, we have a separate divisions which takes care of those allergic and external immune response processes. And autoimmune diseases are a totally different ballgame.
She thinks it is allergy, but she's getting rashes on the skin. So
then I think it's...
doctor suggested it's an autoimmune disease.
It's better if she sees someone of us, I think we can really.
Thank you, doctor. But my suggestion is, please update or give the awareness to the physicians, because I have suffered like hell. More than the patients, physicians should know. what is SLE, what is RA and all that. That's my sincere suggestion. Thank you so much. All the time.
I think, yeah, Srivatsav has some questions. Please go ahead, sir.
Sir, you know very well that my wife is under your treatment for last almost 20 years. But autoimmune has also come, that you know, but she is not improving now at this age of now 74, 75. How to recover her? Because now the problem of urine has come, which is uncontrollable. That is the main cause which has made her further down. And during this COVID, we could not see you for 1 year continuously. So how we can come out of it?
Yeah, I mean, see, we are trying to work out with her actually. See, sometimes the problem in these autoimmune diseases is the drug that we use are immunosuppressive. So that increases the infection episodes. We are, with her case, we are in a trap of, if I increase the medicine for autoimmune control, the infections are increasing. If we reduce that, the autoimmune disease is increasing. I mean, this is one of the major challenge. I think my other colleagues do agree that it's one of the very tough game. It is, I always say that it is walking on a tight rope. You swing this side, you fall onto one fire. If you swing to the another side, you fall onto the different fire. But end of the day, both are fires. So we need to very balancedly work with that. And we really have learned the art over a period of time. But still there is a lot of gap to be filled with reference to that. So we will definitely try to help her how best we can negate those two. Tightrope walk actually.
Now, doctor, as you know, the major problem at the moment is that control of urine, UTI. Medicines continue even now. Again, we are going to consult next week. The moment antibiotic is stopped, within a week, again UTI comes. So is there any way out? Can you suggest by which she can come out of it? This is okay. Other things she has been able to manage. Hepatitis she had been able to manage somehow. But this is such a thing that whole night she cannot sleep. Daytime somehow she is managing now. But night you see 2 times she has to change the pad. So that's become very difficult. And I wish that you give some suggestion for this.
Sure. Dr. Chaitra, anything from the gynec side?
Sir, considering the age of the patient, sir, Shivatsa sir, what happens over a period of time, especially in a post-menopausal woman, the laxity in the pelvic wall increases, sir. But when the urethra has a good support, the urethra in a female is only 4 centimeters, and inevitably she is more prone for urinary tract infection. Yes, one cause could be because immunity is suppressed because of the medication, and she is in a higher risk of having a urinary tract infection. The other causes could be because of the laxity. The leakage of urine could be because of the laxity of the supports, which is more common in a woman after she has her menopause. Also, sir, sometimes what happens post-menopause, the secretions reduces, making the urethral area more dry. And that inevitably she will again be more prone for having a urinary tract infection. In case it is only a urinary tract infection, her symptoms may be burning, maturation, lower abdomen pain, or frequent urination. But if she's having incontinence with stress, like if it is with cough, she's passing urine, or she's not able to control the urine from the urgency to going to the restroom, then a urodynamic study will help us, sir, to see if we can use any other medication to give good support for her, for the support systems in the pelvis.
No, that Dr. Chandrasekhar can tell you better. Now, he has been under his treatment for a long time. Even when this problem came, urine problem, because of COVID, we could not go. She was admitted to his hospital. He has seen it, then advised further. Then we went to a urologist here in Colombia. He is giving treatment for last almost a year. But again, I find that every time the antibiotic is stopped, within a week, UTI again comes. Then again, we consult him, and he has done that flow test and everything. Finally, one day, last time, he was telling that passage is getting blocked, and that's why infection is coming. So is there any way out, whether we have to go for some procedure or something, because this is the major problem for her?
So as
Doctor, you
far as
can tell Dr. Chandrasekhar can understand better, and he can advise me when we
No,
meet.
no, actually, see, the one which you are saying about is actually the gynecologist is the right person. That's why I deviated the question to Dr. Chaitra. Just Chaitra can answer that.
yes, sir.
question.
Sir, if it is anatomical problem, you're saying, sir, there is a blockage for the passage. So what happens, sir? It's a container, and the urine gets collected. When there is an obstruction, the chances of a person having a urinary tract infection increases because the urine is stored for a longer time. And in her more so, what happens is, if it is an anatomical reason, if there is a blockage, yes, sir, it can surgically be corrected. We do urethral dilation to increase the space which is blocked, so that she can the blockage could be obstructed and the urination can be easier.
You see, Euroflow test has been done for her, and that result immediately is not available to me. Otherwise, I would have told you. I can send it to Dr. Chandra. But what
Yes,
happens last time? What he explained like this only. This is the bladder, and then this is the passage. In the
Yes, sir.
passage, somewhere it gets blocked,
Yes.
and because of this, infection comes. So whether if this can be procedure means something has to go from the down and clean it, or what is the way of procedure?
Yes, sir. You do we will pass a tube kind of an instrument which will have a camera at the tip, and that will be passed to see if the wall is collapsing or there is any folds in the wall, any abnormal growth in the wall. So by performing this, we'll be certain that there is some cause which is causing an obstruction in the passage. And if it is there, yes, that can be excised and the passage can be cleared.
Yeah.
Yeah,
I think probably.
Doctor, I think you should know better.
No.
Advise my daughter.
No,
and,
what I suggest you is, if you can, since it's a little personal problem, I think since there are others too. So I would request once, if you can come sometime with all the reports, we can try to help you out on that. It's not at all.
We will come because at present next month sometime we are planning.
Sure.
Sorry, sir.
Yeah. So I think there is one question I think one of you can take up. Can you give us an insight on whether should we consider on food habits? I was told that I can eat anything, but I still observe some rashes when I consume fruits or any unboiled food. Any take on that from Binish and
Yes, sir. Yes, sir. So we know these SLE patients are prone to get atherosclerosis. So they are prone to atherogenic phenomena or myocardial infarctions or heart attacks and all. So to maintain a good lifestyle with a healthy diet, which would include fruits and vegetables in appropriate portion along with the whole grains. So in a way, a healthy, nutritious diet is something that is recommended for all autoimmune patients and especially SLE patients. So this is, this was about food, and some foods like, for example, garlic and some sprouts have been sometimes shown to be avoided. And some people start taking immune boosters or take some herbal medications, which they say that they are immune boosters, but actually they sometimes, they are more detrimental to the, any autoimmune disease. So regarding your rashes and consumption of fruits or unboiled food, so this could not be related actually to your disease per se. This could be some other phenomenon, like you could be allergic to some foods, so which you can check by consulting an allergy specialist or getting your IgE levels or getting these and check for which all fruits and this you get rash. So this could be an entirely different phenomena than the foods that affect any body due to any autoimmune process.
Any clarification required?
Dr. Desai, let me just 1 minute tell you what was the last time he has diagnosed. Last Euroflow showed 398/17/6/15 ml, SCR 0.8. And earlier, every time what is found, once culture shows Klebsiella, then Enterococcus, then Pneumocyodomus, and then Enterococcus. Like that, it goes on happening.
No, I think, see, precisely there is a block that needs to be cleaned up. So actually, what I suggest is, Srivatsa, I'll tell you because since it involves a lot of individual things. So if you can come some down, we will discuss in detail with you.
Okay, doctor.
Yeah, so that the others can discuss on the.
Thank you, doctor.
Yeah.
Thank you.
Because it's a single individual case. Usually we don't discuss because there are others.
You have done a lot for her, but this is a problem which she could not come.
No. Since it's a privacy issue, I just suggested to hold on. So that's
Okay.
nothing else.
Thank you.
I think there is one question. Probably I and Dr. Chaitra should answer that. I have lupus. Can I get married and have a child? Answer to that question is yes. Probably I think Dr. Chaitra can explain her success story with few of the lupus patients, and even Dr. Binish and Shruti can share some of the success stories of how things can work and what are the hurdles that we may face, but how one can negate that.
Yes, sir. So I would be very happy to say the success stories that we've had with lupus patients. As I already mentioned, as an obstetrician, SLE is kind of, it used to give jitters before. But getting more into this, knowing the subject better, and I can say it's clearly a state where you can get married, you can have a healthy pregnancy, you can have a healthy child also. So we'll have a lot of hurdles that we have to face during pregnancy also. Most of the time, sir usually gives them a good instruction as to when they should conceive. If 6 months they are in remission, it's one of the best time that they should conceive. And when they do so, the chances of abortions or having associated medical conditions which do happen in pregnancy is reduced. In a person who do not have remission, or when she's in the active phase and when she conceives, yes, there is a high chance of she having miscarriages. And once you conceived, why you are considered as a high risk? There is a chance that the disease may flare in the first or the second trimester, more so in the first or the second trimester, and most of the time it is controlled well. But sometime in the third trimester, that may lead to an early delivery, like a preterm delivery. Associated conditions are high with SLEs. Some of the SLEs will come with APLA. It's a condition in which the blood flow to the baby is reduced or it's obstructed, and the woman can develop high blood pressure or can have early miscarriages, can have blood pressure in pregnancy, a condition called preeclampsia. Most of the women come with swollen hands and feet, blurring of vision, upper abdominal pain. So this is a kind of an association that the women can have. That is the main reason why we consider her as a high risk. One of the most important thing is, they say in pregnancy, you do only 3 scans. No, madam, why you're doing so many scans to me? Well, that is because some of the antibodies which is present in the mother who is SLE can cross over the placenta and can affect the baby's cardiac. So the baby can have a conductive cardiac defect, which by doing scans routinely, by monitoring the baby's cardiac activity routinely, if there is an abnormality, we can intervene at the right time to prevent this from happening. And recently, sir had seen a patient who delivered and the child had come with rashes. And the child was treated with saying it was a fungal infection for almost 3 months. After 3 months of delivery, when the patient came, we found that it is neonatal lupus. The mother was lupus with very mild symptoms, but she was not diagnosed. But the child was having neonatal lupus. And sir had very clearly assured her that things will settle. We had evaluated the baby for the echo and there was no conductive cardiac defects, only the skin lesions. And now the child is around 9 months and completely cleared of the rashes. And as far as our success story goes, yes, pretty good outcomes. For the past 3 months, we've continuously delivered SLE with pregnancies, and happy to say that most of the babies are above 3 kg. They all had a safe delivery with no intra or post-partum complications. And recently, Binush ma'am's one patient, we are seeing her. She is, this is a second pregnancy. After having 2 abortions, this is a successful pregnancy and things are going well with her. Yes, she will need a little more care from our side. But as sir already mentioned, if the condition is well under control, pregnancy and childbirth should be safe.
Nice. As Dr. Chaitra correctly said, absolutely, we're very happy with the recent delivery of one patient. It was a great success story. So as Dr. Chaitra correctly said, so this disease is to be, before a female gets pregnant, it is very important that her disease remains quiet for at least 6 months. So this leads to a successful delivery and for both the mother as well as the child. Another point is that preconception, that means before planning pregnancy, if the female or a patient of lupus consults a rheumatologist and needs a change in the medication. So because, the problems we get is when the patient, conceives and is on those medications which are harmful to the baby, in the womb. So if it is a planned conception, so the medicines are changed, they're put on proper medications which are not detrimental to the baby as well as to the mother. So, and the mother the disease is quiescent or silent for at least 6 months before she plans the pregnancy. So we have seen wonderful outcomes in those cases. And if they are monitored, as Dr. Chetra correctly said, that there are certain antibodies which cross the placenta and can affect the fetus or the baby in the womb. So if they are checked earlier and the child is monitored in the 28th and those weeks of pregnancy, where we do regular fetal cardiac monitoring. So we prevent the neonatal lupus as well. So these are the cases where we have seen excellent outcome in these patients. That's it.
I think there is one more question. I have lupus, continuity to that, then I'll take one more question. I have lupus, can I breastfeed my baby?
Yes. There are some medications which has to be kept in mind. So as I already mentioned, usually when they have a successful pregnancy outcome, they're in very mild doses of medications which are safe in pregnancy. Definitely, you will have to speak to your rheumatologist as well as your obstetrician on certain medications which has to be kept in mind when you are feeding the baby. But yes, you can and you have to breastfeed the baby.
There is one another question. How many days we need to follow the treatment? And are there any restriction I need to follow in my day-to-day work? Shruti, any answer on that?
Yes, sir. So this question is particularly in specific to the treatment. So when we talk about the treatment in SLE, as we earlier said, it's what we call a chronic condition, so which requires treatment for a longer time. So we're talking about years together. Sometimes the duration of treatment can be as short as 2 to 5 years. Sometimes some people require a lifelong treatment. Okay. And also the number of medicines, the intensity of the treatment we give depend largely upon the symptoms you have. So we do have a quite wide spectrum of symptoms in SLE. So some people just have very mild symptoms where it just affects your skin and the joints. Some people have involvement of the internal organs. So they can involve kidneys, lungs, heart. So if the internal organ involvement is that, the duration of the treatment and the intensity, what we call, so the number of drugs or the amount of immunosuppressants we use also differs. As I said, the internal organ involvement require higher immunosuppression, whereas if you have a milder symptoms, the milder form of immunosuppressants will be used. So they can vary from anywhere from involving steroids, giving you steroids, or different form of immunosuppressants, or even the biological treatment, which are given in the form of injections. Okay. And as we said, the duration, again, as I said, it depends on the symptoms. So that it is all, the treatment is individualized, and they're regularly monitored, they're regularly followed up to look at your response and the side effects. So individually treatment. Next, coming to any restrictions that we are required in the day-to-day life. Again, the whole aim of the treatment that we give is actually to give you the good quality of life and also to give you a life as normal to as possible. So there are no specific restrictions, but there is the alterations or some lifestyle modifications have to be done depending upon your symptoms. Like for example, if you have a lot of joint pains, then you may require some alterations in your workplace. If you're on a lot of immunosuppression, then we advise you to take certain precautions so that we avoid the risk of infections. So there are certain modifications that we advise, but as such, there are no specific restrictions that we would recommend. And going back to the first question, when they said that can I get married was one of the question. So we spoke in length about the pregnancy, but even when you come to the marriage life of the married, because the lupus affects commonly 15 to 40 years of age group, where the women, there are a lot of things in that age group for women, like marriage, pregnancy, career, work, everything. So we don't, the whole aim is actually to make you achieve all your dreams. And in terms of the marriage, one suggestion we give is when you step into a new relationship, be open about your condition, be honest that you have this condition, because it is a lifelong duration. So you have to have a family support. So if you're honest and open about your condition, I think then it works well.
I mean, there is, little more extension. I think I'll take up this question. It's continuing to be discussion on the food, actually. I mean, see, there is a lot of confusion when it comes to the diet. Diet, autoimmune disease is a hotly debated question. Just to recollect, see, when I started my research in immunology, I did believe that there is some sort of influence of the nutrition on immune and inflammatory response. No doubt the diet, nutrition do have an influence on the immune responses. They are not one-to-one relationship. See, there is a confusion that actually, which I really worked through, where there are some confusing terms where you see a lot of website calling some diet as inflammatory, some diet as non-inflammatory, and some diet as cooling, some diet as immune boosting, and some diet immune modulating and modifying. See, to be clear and honest, the studies which I went through, the very properly written studies clearly indicates there is no room for such things to happen. The reason is very clear. The human body adapts to the diet. The human body works to take the diet as a necessity and as a requirement. Every time you eat any food for that matter, let it be just a plain carbohydrate or a high lipid load or a high protein load, body generates a small amount of inflammation which ranges from mild to moderate inflammation. Any food eaten, body secretes the immune inflammatory response. It's a necessity for the food to be digested. It's a necessity for a food response. There is a perennial problem in interpretation of these informations. I mean, it's across the science. I mean, so when a scientists are confused, then I can say that common men are still more confused. And adding to the confusions, there are several classification approach which has come from time immemorial. See, actually, for that matter, my group of some of the alternative system colleagues of mine, we try to decipher the terms that are used in Ayurveda, where they use food of heat consequence, food of cold consequence. I think we have something called thandi and heat type of food items. We try to work on those in details on the science and other dissipations. But to our surprise, the classification of some food items were regionally different. Some items which were called a cold item in southern India was called as a heat item in the northern India, and the same thing between the east and west. So that made us one point clear that there is a confusion in classifications. The next, we tried to work on the component composites and how does it really influences the outcomes. But to our greater extent, it was suggested that it was more a sort of anecdotal and not on a pure science basis classification and approach. So I dropped the project after working on that for 4 to 5 years with only one publications, but it was only publication, but conclusion was not anything useful. So what I meant to say that, say don't go by those websites and WhatsApp messages, which they talk about inflammatory diet, immune boosting diets, immune modification diets, etc. So there is nothing such particular processes that can happen with reference to food and food items. No doubt if you have an allergy, you may develop an allergic reactions to those food protein particles. If you have a gluten sensitivity, lactose intolerance, or some of those intolerance, yes, you can develop an abnormal reactions in response. And there is a lot of reaction that happens between the food items and the gut bacteria and lot of adaptations that the gut takes through the way you expose yourself to the food in the first 10 to 15 years. See, because these are all the things based on which the body adapts to live in an environment. The first 12 to 14 years, the body tries to learn how to live itself in the new environment after it quits out of the well-secured mother's womb. So once it comes out of that, it tries to start work on the adaptability. And we are also learned and understood that even in the womb, it learns a lot of things, what mother is exposed to and what mother has learned, which the mother transfers some of the information across to the child, what are called as new learning or old learning. So there is a lot of processes which body adopts to work towards a successful 40 years of existence. That's what a normal life expectancy, which we have stretched by another 40 years with the modern science. So, but whatsoever, that's how it is. So we are really confused with reference to food. That's why my advice always to most of my patients is, what you love to eat, you eat it, as long as you don't have a metabolic disease. If you don't have a diabetes, which is a metabolic disease, where you need to control your diet because the metabolic process has gone wrong. If you have a metabolic problem like a uric acid, where you need to control that. If you have a sensitivity to some of the food and food particulate matter, avoid them because that's where it is. Otherwise, last choice, I tell that if you psychologically don't accept that food, stop it. It's not going to change the way you're going to, because some people say, the moment I eat non-vegetarian, I get severe pain. The moment I eat a brinjal, I get a severe pain. Okay, you are hating brinjal, stop it. So, that's a whole simple way, but that's how it is. So currently, food, autoimmunity, immune systems, their relationship is still in a question mark. And as we have understood, as far as I have understood from whatever the studies I have gone through, there is no direct one-to-one relationship. It is a highly heterogeneous relationship. So don't go by those inflammations, etc. So to change your lifestyle, what the food you want and what the food you love to eat, you can eat it as long as you have no metabolic disease or no allergies to those drugs. That's my simple advice on that. Actually.
Thank you, doctor. That was my question. Yeah. And one more thing, I'm just taking this forum as an opportunity to thank you especially because I had a lupus flare 9 years back, and the reason for my survival is only you and your.
No. It's science and technology, not me. Actually, I delivered it. That's it.
No, because whichever hospital we go to and we say if we have lupus, they just look at us with a terrified face. Even the doctors and anyone else. But the only hospital where we feel comfortable to come across and we feel confident about ourselves is you and your set of doctors. And currently I'm 24 weeks pregnant and Dr. Chaitra is treating me. So I'm thankful to her as well because I've undergone a lot of things. And she has been very supportive and very positive more than me. So thank you so much.
Thank you. Thanks for appreciation.
Thank you, Ramya.
Thank you.
So I think we are coming to the end of the webinar. So thank you so much, all the doctors. We have learned a lot from this webinar, I think. Thank you so much.
I think there's one last question. I'm having a reddish dot on my both arms. Should I meet the doctor? It could be a sign of lupus. No. See, the presence of reddish dot or presence of skin rashes, not necessarily lupus. So, of course, as I think Srimati Sudha also asked me the same question, that if there is a red rash, which, it's always a confusion. It is like a fever. You can have fever for so many reasons. You can have a rashes for several reasons. So it's one need to check, see what the rashes are, and then need to go through the tests. And that's where one can conclude that whether the problem that you have, is it allergy, lupus flare. For instance, even in a patient who has a lupus, where we have a reasonably concluded lupus, when he or she comes back with a second rash, it is not necessarily the lupus. We do see sometimes patient gets an allergy on top of lupus. He gets some other problems on top of lupus. So it's always a challenge. I mean, we always say medical science and medical therapy is always a challenge. We need to put our mind, put our science analysis into come to some reasonable conclusion and move ahead.
Can I add something to this, sir?
Sure.
So this is actually where the real confusion comes in the physician world. So a patient is adamant that she may have lupus and she has Googled lupus. And then finally she sees reddish spots on her hands and the physician gets an ANA done. And ANA comes 1+, and this is where the real confusion comes. So is the patient having lupus? So having an ANA does not mean that a patient has lupus. With red spots also would not mean that the patient has lupus. There are a certain set of criteria, there are a certain set of symptoms that we evaluate in a patient, and then we get into blood investigations, which finally prove that the patient has lupus. So getting into notion at red spots and getting an ANA done would not, and even being ANA positive would not necessarily mean that the patient has lupus. Am I right, sir?
Yeah, that's right.
But it might be one of the symptoms, right? For SLE, might be.
That is what.
Yeah. No, we are not saying
That's
you
good.
don't have, but
Yeah.
don't get panicked that with a red rash that I have a SLE. I mean, there is one brief question that I think, what is the difference between MMF and Visalone? Oh, it's a big difference. See, the Visalone is what we call as corticosteroids, and mycophenolate mafetil comes under a class of immunomodulators or immunosuppressants. Prednisolone or a Visalone is the corticosteroid, which is a hormone which is secreted in all of us. It's one of the essential hormone for the survival of the human. Without steroids, none of us can survive. If there is a zero steroids, probably patient just collapses with the blood pressure dropped. And we call those kind of patients as Addison's syndrome, which goes by the physician who first time described the deficiency of corticosteroids. The steroid works when it in excess, we call it as non-physiological dose. So normally all of us need around 5 to 7.5 mg of Visalone, which is secreted by ourselves. Body secretes approximately around 5 to 7.5 mg of prednisolone. It's equivalent, not prednisolone, it secretes what we call as glucocorticoids, which we have artificially synthesized into a equivalent called Visalone. When it is given in excess, when it goes beyond the dose, what is physiological, it becomes an immunosuppressive. It starts cutting down the immune system's activity and also reduces inflammation, slowly suppresses immune system as the dose goes up. At 7.5, it is a low immunosuppressant. At double the dose, it is little more. At 1 milligram, it is still high. When it crosses beyond 100 milligram, it almost suppresses the entire immune system. It can almost freeze down the immune system at that point of time. So what Visalone does is totally different. When it comes to mycophenolate, it's a chemical substance which interferes in the DNA and DNA metabolism. It specifically interferes in T cell functioning and few of the lymphocyte functioning and few of the other cells and cell mediators. So that's how it has a very restricted effect compared to the steroid. Steroid goes a pan suppression of the immune system. And in addition, steroid is a metabolic hormone. What it means is it influences not just the immune system, it influences the glucose metabolism, it influences the sodium electrolyte balances, it influences the bone metabolism as an extension of its effect, because it is supposed to increase the glucose level. So as an extension, if I increase the Visalone or increase the steroids, glucose increases. If I alter the steroids, it alters the electrolytes. If it is supposed to move the calcium out of the bone, if I increase the steroid, it moves the calcium out of the bone. Whereas mycophenolate do not do any such because it doesn't have any metabolic interference. And the way they work are totally different, and they are absolutely different class of groups when it comes to pharmacology and these things. But steroid is one of the drug which which has survived and which has given life to billions of people. Though it has a bad name, unfortunately, it has a bad name like a nuclear energy. Nuclear energy, when you use as a bomb on Hiroshima, Nagasaki, I hope they don't use it in this current war, could be very, very problematic. It really can destroy the entire life across. So also the steroid. If you misuse the steroids, it can really cause a trouble, hell of a trouble. But if you use appropriately, it really saves a lot of life. I can tell you, among all the drugs that are discovered to the day, steroid has and steroid should be credited with the saving billions of life. I don't think any other drug would have saved the number of life the steroid has saved to the date. So, I mean, there are two different class drugs, and only problem is, I always tell it is like a nuclear energy. If you know it, you can really use it smoothly. If you don't know it, you mess with it. I hope it has answered your question.
Absolutely.
Yeah. I think we have touched 4:30 with thanks to all the participants and all our patrons who have participated in these discussions. I thank my colleagues, Dr. Binish, Dr. Shruti, and Dr. Chaitra for being a part of these discussions. Thank you very much. I think we'll close the sessions. Any other thing to say? I think